All right, everyone, welcome back to Dementia Care Source. This is part 3 for our Dementia and Swallowing Disorders series. And tonight we're going to be talking all about avoiding aspiration. So if you don't know what aspiration is, you have missed part 1 and part 2, and you've got to go back and check those out. Aspiration is basically when food, liquid, or spit goes down into the lungs, when of course all of that stuff is meant for our bellies. And that is a big part of our job as SLPs, is to talk about avoiding aspiration. So first thing with aspiration is aspiration pneumonia. Miss Megan, can you talk about aspiration pneumonia for us?
Yes. So as we have previously established, aspiration is when any food, liquid, saliva, any foreign object goes below the level of the vocal cords and down into the trachea, into the lungs. So aspiration pneumonia is when you have aspirated something and that is in your lungs and it causes an infection that can be caused by food or by saliva, a variety of things. So we um, it does present as pneumonia. And so, if you have somebody, if you have a loved one or you're caring for somebody who gets frequent pneumonias and they can't figure out why, it could be aspiration pneumonia. And so that's something you might want to look into.
Yes, and I think we'll elaborate on this further, but emphasizing that aspiration pneumonia is a multi-system issue. So it's not just that your pharynx, that your throat isn't working, that your vocal folds aren't protecting your airway, and your epiglottis isn't inverting to protect your airway, and all these little physiology things we know as SLPs, but also that enough of it is getting in your lungs and setting up, and your body's not able to cough it out. You are medically compromised in some way. Maybe you're less active than other people. Even things like for oral health, or that you're dependent for feeding, all these different things can put you at increased risk for aspiration pneumonia.
Definitely.
Yeah. And so, pop quiz, does getting a peg tube, a feeding tube, take away the risk for aspiration pneumonia?
It most certainly does not. It doesn't. So if a lot of people think, well, if they're having trouble swallowing and it's leading to pneumonia, let's just put a feeding tube in their stomach. And that way we don't have to worry about the food going from here down to their stomach. It's just straight into the stomach. But there are a lot of issues with that, or a lot of concerns that need to be considered with that decision. So as you know, there's multiple different reasons why that might not, why having a feeding tube might still lead to aspiration pneumonia. So one of the big things is a lot of times when somebody's on a feeding tube, they're getting constant feeding, which means that they need to be sitting upright. Because if we lay flat and food is in our stomach, we have a much higher risk of that refluxing back up into our throat and aspirating it. And that is something that is very difficult if somebody is getting that feeding tube 24 hours a day. It's hard to keep them sitting up. They might not like it. They might pull to the side. They might have strange positioning, um, which can, still ultimately lead to aspiration pneumonia, regardless of what's happening, um, from here to here, as we say. Another reason that it might lead to, you might still have the risk of aspiration pneumonia with a feeding tube is, as you and I have talked about a lot, Gina, is oral care. So it's not just aspirating your liquids and your solids that could lead to aspirating pneumonia, but any kind of bacteria that gets down into your lungs. So if you have somebody who's not eating, a lot of times people think, oh, well, especially if they don't have any teeth, that we don't need to brush the teeth. We don't need to clean the mouth. But why is that an issue, Gina? I'm going to turn the pop quiz to you.
Oh, I love it. I could talk about spit and saliva way more than our listeners would be interested in hearing. There is, yes, so one huge risk of having the feeding tube is, as Megan just said, you're more at risk for reflux, for those things coming back up into your airway, kind of taking a step backwards here, and also thinking about if you're not allowed to eat or drink and you're also getting 2 feet in your belly And then you aspirate it and it comes back up, and you haven't been swallowing food or liquid down. So then those muscles are weak. They're going to be less likely to protect your airway when the food that went up from your belly to your throat goes back down. It may go in your lungs this time because those muscles are weak,
Exactly.
along with tying back in, like you said, the spit issues that come when you are not able to eat or drink anything. So, saliva is so incredibly important, not only to our comfort, but also our oral health. I want to make sure I word this correctly. I've got my notes here. One of the largest reservoirs for bacteria in the entire body is the mouth. The mouth has the highest number of bacterial species in the whole body. And we know from research that we have changes in our saliva production. Talking specifically with Alzheimer's dementia, we know there's a change in the saliva. And we know saliva also changes when you're not eating and drinking anymore. When you don't have any oral intake, your saliva, the makeup of it actually gets thicker. And from our last video, we know that thicker substances have higher risk of silent aspiration. And it just sets up this perfect storm for us. So back to oral care. Even if you're not eating and drinking, it is unbelievably important to still keep a clean mouth. And I remember even taking care of family members that one was very sick with cancer and they weren't eating and drinking, and they still had, even without a feeding tube, they still had so much just buildup and grime in their mouth because, again, they're not eating or drinking. Their saliva is changing. They don't have enough saliva production to swallow and keep a clean mouth. They're not eating, so no one's cleaning their mouth. So it just got so gunky and dry. This was before I was an SLP. I had no clue. I mean, I knew people should have a clean mouth. That's kind of common sense, but I had no clue that suction oral care was available. So that's something you definitely want to talk to your loved ones in a long-term care. Talk to their nurse about, talk to their doctor about. If you're caring for them at home, their doctor, their home health nurse, whatever. It is a little thing about this big, and it uses pressure to be able to, there's toothette attachments, which are like a little dental swab. There's toothbrush attachments. Yeah, is there anything else I'm missing? I guess there's just a suction part. And so you can use all those with a swab with some oral debridement, some modified saliva replacement, different things. So these aren't things I'd recommend anyone try on their own.
Definitely.
Clearly, if this is the point that someone's needing suction oral care, they're pretty medically fragile, and we want to be very careful, but it's available to you. I wish someone had told me, 19-year-old me, it was available when I was a caregiver. So yeah, talk to your doctor and nurse about that. It's something you can get set up really anywhere. It's not terribly complicated, but it's something you want to make sure you're doing the right way. So
right.
suction
Exactly.
oral care. Yeah, go ahead.
So yeah, you need it in that section to be able to get that spit and that mucus out that's building up in that loved one's mouth, and that you can, the swabs and the toothbrush to really get in there, even if the patient doesn't have teeth, to get in there and to clean the tongue and the inside of the cheeks and the roof of the mouth, and really clean it out in that section to just make sure there's nothing building up, because there's a lot of bacteria, like you said, and even especially when you are a mouth breather, you're just breathing in and your mouth is going to get so dry and it's going to get so miserable, and you're just really have a decrease in your quality of life at that point, because nobody likes to have a dry mouth. And if you don't clean it, then it's going to get caked. That mucus is just going to kind of dry out and be kind of caked in there. And then that mucus, if it forms into, if you don't keep it clean, it can get kind of dried out and form into like a bigger chunk, to put it nicely. And then if that, that just harbors bacteria, and then if that kind of breaks loose and the patient ingests that into their lungs, then that is a perfect storm for aspiration pneumonia. So it's very, very important to really constantly just keep their mouth clean. even if they are eating, to make sure that their mouth gets cleaned at least twice a day. If they have dentures, take those dentures out and clean them out really well, because they harbor bacteria. I can't tell you the number of times I've taken out, upper dentures to find, food and green bean strings and nasty, just all sorts of gunk that was in the dentures against the roof of their mouth. And that just can't be comfortable either. So it's really important to get in there and clean out your loved one's mouth.
Yeah, absolutely. I mean, I have found, I don't know how much I can share. I found mold. And it's just not, it's an easy thing to just kind of put on the back burner. But that's just why we both wanted to take some time to talk about it, because we both get referrals, I know, for patients in like our long-term care facilities and nursing homes, and they say, oh, they're not eating. So that's a part of every evaluation that I know we do, is we look at that, their mouth, their teeth, their gum line, a little hangy ball. We look at all that. And I gotta say, so often I'm like, well, it's probably because their mouth looks like this. And I might spend 15, 30 minutes just cleaning all of their mouth out.
Yeah.
So super, super important. Again, not something you as caregivers have to know how to do on your own. If your loved one is dependent for that, talk to your doctors and nurses, talk to your SLPs. And don't be afraid that if your loved one is still, walking up to going to the bathroom and washing their hands, and they're kind of able to do some of these activities of daily living, they can probably still brush their teeth.
Yeah.
Hand them toothbrush, toothpaste, water in a cup. And if there's, talk to their doctor, make sure, again, if there's big concern that they might swallow the water and you've had a SLP or a doctor say it's not safe for them to have water, okay, you need to take that into consideration. But,
right.
If there's not a major diet restriction in place, a lot of people can still brush their own teeth in the earlier stages of dementia.
Exactly. Again, even if they don't have teeth, they still need to brush their dentures and brush their mouth. I can't tell you how many times I've had patients look at me and be like, well, I don't have teeth. What are you going to brush them? Because that, like you said, the roof of your mouth and that tongue just really builds up bacteria so much. So
yes. And one side caveat, and also shameless plug for a future video that we're going to do about how to help people with dementia to encourage them to eat and drink more, while we're talking about oral care and comfort. Why no one would want to eat when their mouth looks like that and they're not of the cognitive and language ability to say, oh, my mouth feels dry and my tongue's dirty and whatever. So as I said earlier, we know the salivary flow, the saliva you produce, the amount of it changes with Alzheimer's, dementia, and just generally across the geriatric population as a whole. So what will help you make more saliva is modifications in taste, temperature, and touch. So we'll be talking more about that in one of the future videos we've got planned about feeding strategies. Getting excited for that already.
Right.
And so if you do have someone that that they're either reporting or they're showing these signs of having inadequate spit or reduced salivary flow, if you're writing it down medically. So there are kind of three approaches I take to that. And the first one is going to be salivary substitute products. So talk to your doctor or nurse about this. There are things you can get over the counter. And just a quick internet search will give you some brand names that I'll try not to say out loud. But salivary substitute products. And I was just talking to Megan before the video started. I was just reading a research article that talked about how actually near your hanging ball, so the top and back of your mouth, is actually where we have the greatest loss of saliva content. So whenever I've done salivary substitute, I've kind of gone along like the tongue to administer them, but we may have to change that up.
There you go. Research is a beautiful thing.
We're learning all the time. That just is still blowing my mind. So treatments, the salivary substitute products, toothbrushing, as we talked about, we know that toothbrush can increase your salivary flow, which sounds kind of gross, but that makes sense to me because I always remember after brushing my teeth, like I have to spit a little bit more.
Yeah.
Which sounds gross, but
it works.
It's really a cheap, easy fix for our people that are having dry mouth, and just have them brush their teeth before and after they eat.
Yes.
That's extra important. And then the third option is medication as an SLP. I'm not a medical doctor. I am not going to recommend any medications, but it may be a conversation you want to have with your doctor. So we have gone over aspiration pneumonia, how it can be caused from a PEG tube. Want to take a second talking about what aspiration is not. Aspiration in itself, it sounds like a big scary word, but it is not in itself a death sentence. So if someone comes to you and they say, we have done the swallow study and we find out that your dad is aspirating, that does not mean if you eat or drink this, they will die tomorrow. That's just not true. Last week, I had a modified of a young man, so very mobile, good oral care, in his 50s. I mean, overall, just a healthy, active individual. And he aspirated a bunch. And so we kind of had to have this talk of, he's not having repeat pneumonias. He says he's never had pneumonia before. His doctors are following him very closely. So, we kind of had this conversation about, we're going to talk about later, the pillars of aspiration pneumonia, how to avoid aspiration pneumonia.
Right.
But you can aspirate and keep going.
Mm-hmm.
I know I did a FEES, which is the swallow study in the nose, where you can see their airway. And I know another SLP that aspirated like a whole Dorito on her swallow study, and she's fine. She has not been admitted for aspiration pneumonia.
Mm-hmm.
So just don't take it as an immediate death sentence or an ultimatum in any way. One interesting thing is we don't know how much aspiration it takes to cause pneumonia.
Right. And just from my personal experience, I really think it depends on the person. I think that, some people can, aspirate a little bit and get pneumonia immediately, and others can aspirate a large percentage. And as long as they're mobile, as long as they're, having good oral care and not letting that bacteria build up and they're moving, they can be just fine and not have any issue. So I really think it is a bit just, and this is just from personal experience and who I have worked with over the years. um, Everybody's lungs are different, and some lungs can just manage it and keep going and not have issues. So I think that is, obviously we want to, take aspiration seriously, but it is not a death sentence. Like you said, it does not mean, if they aspirated at one point, that doesn't mean that they can never eat again. It might mean some different modifications or something based on, that your loved one's personal swallow function. There's a lot of reasons that people aspirate, and so it is very person dependent. Um, but yeah, like you said, Gina, it's not a death sentence.
Yeah. So it's something to take seriously. It's something to do your research on, to collaborate. We want that holistic care. We want our patients' wishes honored.
Yes.
But yeah, seeing some aspiration is not the end all be all. So
Right.
just a word of comfort.
Yeah.
All right. So let's get on to the pillars of aspiration. So there are 3 pillars of aspiration. I highly recommend looking this up online to get more familiar with it. But it's basically saying for someone to develop aspiration pneumonia, we look at 3 things. So the first thing is oral health, which we've already talked all about. Make sure that they have got a clean mouth. If you're really worried about salivation, brushing their teeth before and after meals, looking at saliva substitutes. So oral care is number 1. And then number 2 thing that causes aspiration pneumonia is going to be a high incidence of aspirated swallows. Kind of a long term. So just to unpack that a little bit, is not just one they just aspirate, like my friend that aspirated the Dorito, she's not going to get aspiration pneumonia. She doesn't do that often. It was a glitch. So we don't know the percentage because everyone's so different. You know, if I aspirate a teaspoon of water versus a 95-year-old with MS and cerebral palsy and dementia aspirates, it's going to be a little different.
Right.
So we just know they have to have a high incidence of times that they swallow that it's going in their lungs.
Mm-hmm.
And then they have to have the third pillar is severely impaired health. So aspiration pneumonia is something that's kind of takes advantage of all these other things not going well. Then that aspiration pneumonia is much more likely to want to move in.
Yes. That person is already so compromised physically that it doesn't take that much to get them a little bit more sick,
Right.
unfortunately.
Exactly. Exactly. So, our last point tonight, we are going to talk a little bit about tonight, and I think a lot more on our next one is aspiration and feeding tubes. So, we kind of talked about this a little bit already, but even today at work, we were talking about how there can be this hypervigilance for patient safety and liability. So, sometimes out of that is this old school way of thought of thinking, oh, well, we don't want them to aspirate, so we'll put in a feeding tube
Yeah.
because feeding tubes keep them from aspirating. But as we've already talked about, that's not true.
Right. Exactly.
Yeah. I mean, I feel like even when we were in school, there was such a large body of thought to, we used to think, oh, they're aspirating and it's not safe for them to eat or drink. And now we just have so much more research under our
Yeah.
belt. We know the risk, just like we've talked about in the last few minutes, the risk of being NPO, the risk of aspirating on reflux, and the complications that can come along with feeding tube. And I think as a whole, our practices and recommendations are starting to shift a little bit.
Definitely. Yes. Yeah, there has, and that's one of the things I love about our field is that we do a lot of research. We, have grown so much in so many areas over the last few years with just new research. And that's why, we as medical professionals need to be looking for that research and willing to, change our approach and change our recommendations based on what the most current research is saying. Um, and it definitely has changed recently. So,
Yeah. I
yeah,
mean, in the last year, I know I've been in the room with a doctor that told the patient, and we've all got stories like this, but he just looked right at the patient and said, well, you're aspirating. And so if you don't want to die, you need to have this feeding tube put in. And I was like, come here, let's talk. Let's talk in the hallway. No.
yes,
And there's all kinds of ethics and best practices out there. But just, for our dementia caregivers, that talking about aspiration and talking about feeding tubes, everyone is so different. And it's just a long and important conversation. And I know that's why a lot of you are watching this series is because we're talking about swallowing disorders, and you may be having to make the decision, are we going to give mom a feeding tube, or do we do this thing called comfort measures? You're trying to wade through those waters, and you can feel really alone.
yeah,
So, we're here for you. If there's not an SLP on your team where you're at, just ask for a speech referral. And I just hope that this gives the opportunity for a little bit more education and understanding to what we're looking at when we're considering those recommendations. And we're talking about aspiration and talking about NPO. So yeah, we won't get into all of it tonight. We'll be mostly talking about in the next episode, NPO and feeding tubes and alternative means of nutrition. And then our last episode, like I was talking about earlier, is going to be those helpful tricks for getting people with dementia to eat.
yeah. It's good stuff. I know it is very hard as a caregiver to make these decisions. And I never want anybody to feel alone. So please, ask. Um, now that you have heard our opinions, hopefully you have a little more information that you can go to the doctor and ask for that swallow evaluation and do more education so that you can really fight for your loved one and make those decisions informed and not just because a doctor came and said, hey, if you want your loved one to stay alive, you have to do a feeding tube because they're aspirating. And so you choose if they starve to death or if you do a feeding tube. That hurts my soul to hear that. So I want to encourage family members to reach out and to ask for more education, um, especially in those circumstances. That it's a big decision, and you don't have to do it alone. So
Yeah, that's awesome. That's what we're here for. That's like my motto. It's a lot, but you're not alone. So, yes.
There you go. There
Yeah.
you go.
Great. All right. So we will see you guys again at the next episode.
Sounds good. Thank you for having me, Gina.
Thanks, Megan.